I'm here today with my friend Dr. Allison Nakanishi, who's a geriatrician here in Victoria. She sees a broad mix of patients, and we wanted to talk today just about, mostly about what it is that you do as a geriatrician and the sort of things that we can do to help the patients that you see. Maybe before we start with the questions, are you able to tell me a little bit about your background and how you got to where you are now?
Oh, sure. I did my medical school training and my geriatrics and internal medicine training through UBC. And then a few years ago, we moved over to Victoria.
Yeah.
And so I've been practicing as a community geriatrician here since roughly 2020.
Okay. Yeah, and that's where we met, was at medical school. So yeah, many fun times in medical school and then off to different places. So yeah, but still staying in BC, exactly. Which is where we're kind of focusing on. And then, I guess I'm interested in what it was that drew you to geriatrics as a practice as well.
Interestingly, we get asked that question a lot.
Yeah.
Because I think it attracts kind of a certain personality. But ultimately for me, it was like, I really like getting to know somebody and their situation and subsequently developing a care plan around that, as opposed to starting with guidelines or numbers, really more just the patient-centered care.
Mm-hmm. Yeah, it's interesting in medicine how a lot of the time it comes down to the relationship that you can have with patients and the team that you work with and your ability to sort of affect change. I've noticed that, especially as I get more and more into practice, it becomes less and less about this sort of nature of the work that we do and more about the people that we see and the people that we work with.
Absolutely. I think you really need to meet somebody where they are. Yeah,
exactly. So can you tell me a little bit about your day-to-day practice as a geriatrician? What does your sort of bread and butter look like?
So as community geriatricians, we are either spending our days seeing consults in the hospitals or working in our clinics. Some of us have roles in addition to that, like teaching medical students and residents or in leadership and administration. But it's very clinical-based work most of the time.
So you're spending most of your time sort of seeing patients or working with teams of people who are seeing patients.
That's correct.
As opposed to doing sort of broader policy level work or anything like that.
Yeah. Some people do choose to do that, but the bread and butter is the clinical medicine and, as you mentioned, kind of working in particular in interprofessional teams.
Yeah. Who are the other members of the interprofessional team that you work with?
So we generally have a geriatrics nurse.
Because you guys have that GEM team, you call it, right?
That's right. Yeah. So there's a nurse, an occupational therapist, physiotherapists, and rehab assistants that generally make up our team.
Mm-hmm.
In our outpatient clinics, we also have social workers and have some affiliation with the kind of cognitive health initiative and some of the research opportunities through them. Yeah.
And cognitive health initiatives, so primarily focusing on major neurocognitive disorders and dementia?
That's right.
Yeah, okay. Is that what you see a lot of, or is it a mix?
So we do see a lot of essentially dementia or major neurocognitive disorder, as it's now called.
Mm-hmm.
But that kind of falls under the umbrella of geriatric syndromes, which aren't necessarily a very commonly known diagnoses,
like frailty
or problem.
Exactly. Functional decline.
More syndromes that impact one's function and quality of life,
mm-hmm.
like dementia or falls or frailty or incontinence. The list goes on for us.
Yeah, without a specific sort of organ-based diagnosis or something, you're not focused on an organ system, you're focused on the person and perhaps their sort of decline as they age. What's the best part of your clinical day? Or even you're not even necessarily your clinical day. What's the best part of your day? At work.
The best part of my day, I think, is getting to hear people's stories from all walks of life and with the experience that they've gained over the years, and subsequently, them having the opportunity to feel heard.
It's funny because I have I agree. I think the best part of my day is talking to people and hearing their stories and trying to understand them a little bit. And I talk about that, and I even talked about it back when I did my residency applications. And Sky makes fun of me for it all the time. It's like, oh, stories. And I'm like, no, it really, really matters. Like the narration of things really matters. I think it matters a lot. Yeah. But she's an emergency doctor, so it's a very different paradigm and very different, she doesn't see people as many times over, so I don't think there's as much opportunity, but I don't know. I find it really important, and I do. And what are the kinds of problems that you're seeing that you're helping patients and their families or loved ones through?
Yeah, so I think, very similar to us addressing kind of the geriatric syndromes, having a more kind of functional and quality of life lens when we see people.
Yeah.
And all the things that kind of come along with that, and particularly with care for major neurocognitive disorders, caregivers are often seen as part of the team alongside the patient, like we see people together.
Yeah.
Or as a family, or whatever their support kind of unit looks like.
Mm-hmm.
And also trying to provide caregivers with support, particularly through our outpatient clinic.
Right, okay. And so you guys have the social workers, the occupational therapists, who are a lot of the time, it sounds like, involved in providing caregiver support almost as much as patient support. That it's like, how can we help you help your loved one sort of succeed or be independent or have good quality of life?
Exactly.
Yeah.
And everyone has a slightly different lens to that, whether it's looking at, making the home a safer and easier place for patients to live, or reframing and trying to address maybe even some of the stigma associated with major neurocognitive disorders.
Mm-hmm.
Everything.
Yeah. It's a challenging dynamic because it's sort of a whole person concept, but then you can't really say like, oh, we're going to look at this one particular small thing and improve that. But it can be hard. I agree. It's sort of interesting to see the you talked about quality of life, and we think of that as our sort of purview as palliative care doctors over on the palliative care side. And there's this sort of odd, almost synergy, but also line in the sand between geriatrics seeing often sort of these frailty and dementia trajectories, and palliative care, which is traditionally focused on malignancy and cancers, but now sort of see a lot more sort of end stage organ failure, but an interesting kind of dynamic where there's almost two different approaches to that. And in the media, it's often sort of conflated. Like you see the Jerry Pal podcast, you see all these things where we're put together in a group, and probably we should be. But in practice, it's often very difficult for us on the palliative care side to help in any meaningful way with the geriatrics population, with the sort of dementia population. I've seen dementia patients admitted to hospice and have pretty poor experiences actually because of their wandering, and hospice is this sort of very permissive environment. So there's it's an interesting dynamic there between geriatrics and palliative care, and how we can help, especially with the prognostic piece where palliative care is often very intensive for these short periods of time. They're probably seeing patients over a long time in that.
Mm-hmm. Yeah, I think there is a lot of overlap, and I agree with you that we do end up practicing in more silos.
Yeah.
And sometimes that's not necessarily to the benefit of the patient. So definitely something that is a further discussion that could be explored further.
Yeah, definitely. What do you think is the most important thing for caregivers to know about looking after an aging loved one?
From my experience, I think it's recognizing that it's a different role for them than what they may feel like they kind of just transitioned into as a spouse, family member or friend. And it has kind of physical and emotional, consequences. And it's not always negative. Like a lot of people see people being a caregiver role as something that is very rewarding to them, something that they want to do, and we, support them with that. But there are really, I guess, I just would want caregivers to know that they are not alone. I see a lot of people in the clinic who are just, trudging through and making it work, partly because it's a longer haul, as you spoke to, the palliative lens is perhaps a bit of a shorter course, but for us, it is kind of a longer course for things. And for that reason, there are dedicated groups in the community to support caregivers with developing coping skills, to share experiences,
there's podcasts
to address their
Yeah.
concerns. Yeah, and so connecting with those types of things I think are really important if you have the capacity to do so outside of what you're already doing in the day-to-day.
It's been eye-opening with Gravity to see just how many people are acting as family caregivers or as caregivers to a loved one, and sort of learn more about the amount of support that's available out there, which in some cases is a lot, and in other cases people can be quite isolated, and it can be quite an isolating feeling to feel like I'm the only one doing this. We talk about the sandwich generation of people who are, often having kids at an older age now, and so people who are looking after young kids and also looking after their aging parents, especially if they have sort of a diagnosis of earlier dementia or earlier frailty or something like that. It can be really challenging. Yeah. One of the things that comes up a lot in those conversations that I hear and that I see is about the transition either from from home to, say, assisted living, or even into long-term care. And I'm curious how you approach that conversation with either your patients or their family caregivers about how to balance the benefits of remaining at home versus the benefits of going into long-term care. Because certainly what I've seen a lot of the time is that patients very much want to be at home, and family members are often advocating for them to be in some sort of, quote unquote, safer setting. What do you find has been some of the challenges or some of the ways that you've approached that conversation with families?
This is a very tough question to answer and a tough conversation to have, I think, every time. And I'd be curious to know actually how some of our social workers or other kind of allied health professionals have this conversation with families too. I guess the first question I will generally ask is trying to stay kind of patient-centered and with a shared decision-making approach as much as possible. So, getting to know the person, what works for them in the home, what their longer standing wishes were themselves.
Yeah.
And if we can try and honor those for as long as possible, which I find a lot of caregivers do know and do try to honor. And then we want to understand kind of how somebody is functioning in their own home and why, with respect to how they're managing their mobility and their personal care and kind of the other household responsibilities that need to be done as well.
Right.
And then looking at what supports are needed and can kind of practically be put in place for that person. And sometimes that involves, altering the environment if there are stairs and mobility issues, or bringing in equipment that makes the day-to-day easier or reduces falls risks, things like that. And then the next step would be looking at bringing in supports and what that looks like for people too, like
supports like HCAs or CHW.
Yeah, I guess I think of it kind of in two different tiers. There are some that would be, for housekeeping, for meal delivery, things that are convenient. Yeah. And sort of allow people to kind of focus their energy perhaps on other more important, meaningful things to them. And then the HCA kind of personal care piece. Yeah. And what that would look like for that person. Yeah. Yeah, and then I guess above, or separate to that as well, would be the sort of medical care, like home care nursing and stuff, and what they need from that. Do you do home visits as part of your practice? Very infrequently. Okay. There are a few physicians who do that outside of the geriatrics division, and sometimes we will do them. Right. Yeah, but generally I think because of the kind of demand for our services and the wait times for what we already have established in our day-to-day jobs, it's not something that we can that as a division we have decided we can do up until this point. Right, like taking a full half day as a practical matter if you could see, sick patients in clinic or one patient at home. Yeah. But as a whole, geriatric specialty services does have that. Like the geriatric psychiatrists who are our colleagues, and some of the trained geriatric specialized services, other clinicians like nurses and social workers do have an outreach team. Okay, so that's, and is that the SORT team? I don't know the acronyms as well. Yeah. But, yeah. Previously known as SORT. Oh, okay. Yeah. All right. With a name that's ever changing. Under GSS and HSU. Okay. Anyways, a whole bunch of acronyms, but just to say that there is a specialized geriatrics team that can provide more home-based care.
Right.
It's just not geriatricians at the moment.
Gotcha. Okay. And that's like physician assessments, nursing assessments, and HCA assessments, all of those. Okay.